So I was going to make a video out of this, but I thought just explaining this on the slides would be okay. So this is um, an introduction to the next part. It will be just a short part about the cortical area and perception, and then we'll get into uh, today's lecture, which is all about um, application of what we've been learning. So from the maybe we go back just a bit of where we were. Okay, so we had fibers coming in. All right, those that were coming in from the nasal, they crossed at the optic chiasm, and those that were coming in from temporal side of each side of the eye, they moved laterally. Okay, and they in a very specific way. They synapsed in the LGBs, 90% of them synapsed in the LGBs, and some of them went to another component of the CNS, which we'll talk about later. After that, we see that now they go to the occipital lobe, and also in a very particular way. Something that I would like to mention, maybe just before I move on to uh, that component, is uh, the calcrine tracts have, if you've seen here, there are two components. There's a superior one, which ends on the superior component, which ends on the superior component of the cortex, and we also have an inferior one, which ends on the inferior component of the cortex. I think this will help us in explaining some of this. So the cortex itself is divided into the primary visual cortex and the secondary visual cortex. And then we see that the most posterior, which is dark blue here, is the macula. This is where, if you go back to um, the anatomy uh, of our eye, and you see the retina, the macular part, all those fibers that come from there, they synapse here. And if you take a concentric picture of that, the area just around the macula is this whiter area, and then it keeps on moving just like that in a concentric movement in relation to the retina. Uh, so the primary visual cortex is also known as V1, or the striate cortex. And you've just heard me talk about the pathway in the calcrine having a superior and an inferior um, movement. The superior one ends on the striate cortex, or the V1. So the things that terminate, the fibers that terminate in this area, are all about direct visual signals from the eyes. But we do have this macular component of the retina that is the largest. You could gather from the fact that acuity is the highest in this area, therefore it could be the largest. So yeah, that reason stands. The peripheral part of the retina terminate or on or at the concentric half. Okay, concentric half circles anterior to the pole. All right, and then we have the upper portion of the retina represented superiorly. All right. Now, so if the retina is represented exactly the way it is on the cortex, it means that even whatever is saying, because remember we said that the retina has an image upside down, and um, the way that is represented in the retina is exactly the way that it is represented in the cortex. But the perception of the image is flipped, okay, so that you see upright. Um, so just to explain this further, the occipital lobe is right at the back, and you have the macular component right at the posterior, which is followed by this binocular component here, and then we have a monocular component in the periphery. If we look at it this way, you have the sulcus, the calcarine sulcus, right in the middle, and on the up we have the upper component representing the upper part of the retina, and the lower component representing the lower part of the retina. Another thing that you should know about the primary visual cortex is that the LGN also have a point for point representation, or the LGB. LGN mean lateral geniculate nucleus, the same as lateral geniculate bodies. So they also have a very point to point representation on the primary visual cortex. And the visual cortex itself is 6 layered. So you have axons of the magnocellular synapsing on 4C alpha layers of the visual cortex, parvocellular 4C betas. And then the intralaminar regions end in layers 2 and 3. And we have specific components that have been put there with a reminder for you on how that looks like visual. So what about the secondary one? What is it about? This is an association area, and signals are transmitted to this area for the sake of analysis of visual meanings. So it's not only about what you have seen, but what they mean. So all sides of the visual cortex have a Brodmann's area 18, where the signals of the primary visual cortex pass next, and other areas of the association decipher the rest of the image. So what this is saying is that while what you're seeing goes to V1, uh, association or deciphering the rest of the image in context also has to go through V2. Now, the association areas include the following. So V1 is not an association area, but it's the primary one. So this primary visual cortex receives input from the LGN and begins processing in terms of orientation edges. And then we have V2, V3, and VP coming in with a continuation of the processing, and also puts in the aspect of the larger visual field. So if you're looking at something, if you're looking at a bottle, whatever it is that you look that you is whose rays are coming into your eyes, and you're not necessarily focusing on them, those are processed by V2 and V3. V3A processes motion, okay, while MT and V5 also process control of movement and not only motion. LO has a recognition of large objects, and then V8 has to do with color vision. V7 and V4V are also involved, but we don't quite know what their role is. So that's very imperative to know that these are all involved in noting not only the depth, the width, the movements, the colors, but they're there to give you an entire perception of what you're looking at. And so, just to round it up, this is how they appear. Okay, the cortical areas is how they appear. So you have V1, all right, and V1, of course, has that macular posterior end, and then you have V2 and V3 surrounding it, V3A, and then finally V7. And on the sides, we have V8 for color, and so on and so forth. To conclude, uh, you should know that signals from both eyes they separate until layer 4 and VC. So they enter specific columns, alternating and deciphering occurs to correspond areas of the retina in each of the areas. So it's very specific type of information that is going to the brain. And information is also used to adjust directional gaze so that both eyes are in sync. Um, this is called stereopsis. Okay, so having learned that, now I'm going to introduce you to a few terms that are going to answer the question, so what? So what? Why are we bothered about how these things move? Why are we bothered about where they terminate? I think I've always said it in class, and I'm going to say it again. The reason why we bother to learn about how things move is so that we can trace back. We can trace back if we have physical symptoms. We can say, oh wow, okay, I'm seeing these physical symptoms because there's most likely something happening here. And you can only say there's only something happening here if you know where here is. And here is where here can only be where something started. So you have to know the A to the Z for you to say the problem is R. Okay. And so I'm going to introduce you to some terms before we get on. First of all, let's go back. We had a lot of rehearsal when it came to visual field. So the left visual field is the one for the left eye in this case, and the right visual field is the one for the right eye. So if I said that the temporal field of the left visual field, I'm talking about the left side of the left eye. Okay, so we had a lot of rehearsal in naming the visual fields. So if you didn't get the gist of it, please go back to the previous slides and just repeat that rehearsal that we had until we master what it is. And so whatever we're going to see as an injury is going to be manifested in somebody not being able to see something. So it's either the person is able to see everything, they've got no problems, um, or maybe they can't see something in the on the right side of the right eye. Okay, so if they can't see something only in one eye, then you're going to have to draw just one of these. You're going to have to draw the right visual field, and then you're going to draw black in the part that they can't see. All right, so that's how these things work. If they can't see the right side of both visual fields, it means that they can't see on the temporal side of the right eye, and they can't see on the nasal side of the right eye. If they can't see on the left side of both visual fields, it means the left side of the left visual field and the left side of the right visual field are all darkened. So we're talking about the second one. If they can't see on the temporal side of both visual fields, then you're talking of the third one. So the temporal sides of the right eye and the temporal side of the left eye, both of them can be seen. Now, please remember that these are standing for the visual fields, because you cannot always go and look at the retina and say the problem is with this retina. The immediate symptom that you'll get is what the patient is going to tell you to say, this part of my vision is blurry, which part then they will describe. Or it can also be the nasal side of both visual field, which is the last one. Now, those are not the words that I used. So you can't just go there and say it's the nasal side of and write it down the nasal side of both. Well, it could be descriptive, but then names for this. So we're going to go through those terms. So injury to any part of the optic pathway causes a visual defect. That's where we're coming from. But the loss of vision in one visual field is known as anopia, right? R from the word without. And loss of vision in one half of a visual field. So all of these actually have just one half. That is known as hemianopia. All right, there's no vision in a half of a visual field, whether it's the right side or the left side, one half of it is affected. So that is hemianopia. When it is the entire, let's say the right eye, I can't see anything from my right eye. If I close my left eye, I can't see anything. That is known as anopia. It means the whole visual field of the right eye is affected. If it's only I close my left eye and then I say I can't see on my right side. That's the temporal side of the right eye. That means it is hemianopia because the other side of the visual field of the right eye is okay. The other one I'd like to introduce you to is known as homonymous. When someone says homonymous, it means it's affecting the same part of the visual field. Now, the same part, homonymous, it means left or right. So, homonymous has to do with direction. If I say left homonymous, it means it's affecting the left side of each visual field. All right, so each visual field means for the right eye and for left eye. So left visual field, left homonymous visual field, it means the left side of the left eye, which is the temporal side, and the left side of the right eye, which is the nasal side of the right eye. So that's left homonymous. So the full one, because of course it's half, would be left homonymous hemianopia. So that is something that we have on the second one. The first on the third one. The second one is a right homonymous hemianopia. If you notice, they're both on the right side of each of the visual fields and they're half, so that makes it right homonymous hemianopia. All right. Then the last one is known as heteronymous. So heteronymous is where you have different sides or different parts of the visual field of each eye being affected. So you have, uh, let's say, the left side of the left eye and the right side of the right eye. So because it's not the same direction, it's not left left, it's left right of either eye. So you will say it is heteronymous. So if we look at diagram number 4, if you see, it's darkened on the left side of the left eye and on the right side of the right eye. So that's left and right. So that is heteronymous, and because it's half, it's hemianopia. All right, but if you notice, they've got a name in common. All right, if I had to call them temporal or nasal, so this on the left side is the temporal side that is affected, and on the right side is also the temporal side that is affected. So since it's two temporals that are affected, you can say bitemporal heteronymous hemianopia. Okay, so then somebody would know whether it was on the side on the right side, or it was on the left side where both of them are affected. Because if I say heteronymous hemianopia, it could be that the nasal parts were affected, or it could be that the temporal parts were affected. So I have to name them. So it's bitemporal heteronymous hemianopia. And if it's the nasal side that were affected, remember for the left side, the nasal part is on the right, and for the right eye, the nasal part is on the left. So that is heteronymous, but they're on the nasal. So we are now saying binasal heteronymous hemianopia. All right. Okay. let's go into exercise time. Um, what would you call a defect in the entire right eye? Perfect. What would you call a defect in the right side of the right eye and left side of the right eye and the I beg your pardon, right side of the right eye and left side of the right eye? Yeah. All right. What about the right side of the right eye and left side of the left eye? Okay. The right side of the right eye and the right side of the left eye. All right. So go through these and see if you could um, name them, and from there, we can now go to the next slide. All right, so what we have here from the onset, you can tell what the problem is. From the onset, you could tell that the problem is with the left side of the left eye and the right side of the right eye. So that is different sides, so that is heteronymous. Yeah. If it is heteronymous, what is it? Is it nasal or is it um, temporal? It's temporal. So it is bitemporal heteronymous hemianopia. All right. So what this diagram is giving us is different lesions that can occur um, on so let's say you had this ability to tell where the lesion is, and we just want you to say what this patient would have. So we're working the other way around. So we have A, B, C, and D. So maybe for now, I'm going to remove this. Okay. So what we have here is we have a lesion at A, a lesion at B, a lesion at C, and a lesion at D. So let's follow A. If you had a lesion at A, what you do is you follow the tracts backwards to all the way to the visual fields. So if A was cut, it means you're cutting off signals from both the left and right hemiretiny, and therefore cutting off signal from the left and right part of the left visual field of the left eye, right? Okay, so it means the entire visual field is affected. So if you cut it at A, you have anopia of the left eye. Okay, let's see what the first one says. So if you cut off the optic nerve of the left eye, both the nasal and the temporal field of the left eye will be affected. Okay, so that would be anopia. Good. And then it also says outer part of the optic chiasm in both eyes is affected. Oh, that's B. So let's go to B. So if we had B where we right in the middle of the chiasm, what would be affected? Let's go back. What would be affected? So it's the fibers that are crossing. Okay, so one is coming in from the right eye and the other one is coming in from the left eye. Okay, and both of these are coming in from the left hemiretiny of the one is coming from the left hemiretiny of the left eye, and the other one is coming in from the right hemiretiny. Sorry, let me say that again. One is coming from the right hemiretiny of the left eye, and the other one is coming from the left hemiretiny of the right eye. But if we're going to just use nasal and temporal, the one is coming in from the nasal side, and so is the other one. But where are they coming from when it comes to the visual field? So let's follow where their arrows are pointing. So this one, let's start with the left eye. Left eye is coming in from the temporal side of the left eye, and the other one is coming in from the temporal side of the right eye. Oh, okay. So this one, the left side, is coming in from the left, and on the right eye, it's coming in from the right. So I'm guessing that is heteronymous. Okay, so because it is heteronymous, what type? It's on the temporal side, so it's bitemporal. All right, so let's see if this is what we say here. So both eyes are affected, yes. The right nasal field and right nasal field and left nasal field. Okay, let's see if that's correct. Okay, I think I would rather say the right. Okay, both eyes, that's the right. Okay, let's type that together. Right hemiretiny of the left eye. Okay, and left hemiretiny. I think that would bring up better understanding. Okay, and then we have the right hemiretiny. Okay, so let's change that. Right hemiretiny of the right eye. Let's see if we're okay with that. So, I'm sorry. Okay. Yeah, that's looks better. So the right hemiretiny of the left eye and the left hemiretiny of the right eye, those are affected. Okay. And what are these going to affect in terms of the visual field? Okay, so these are looking at the temporal visual fields of both eyes. Okay, so if the temporal visual fields of both eyes are affected, it means that there is a bitemporal, and let's put another one, heteronymous. Yes, heteronymous. Okay, let's see if we spelled that correctly. Heteronymous, yes. So it is bitemporal heteronymous hemianopia. That's B. All right. Okay, so we can now go on to the next one. All right, so let's see if we were correct on B. Yes, we were correct on B. So again, I'm going to remove this so that we can exercise this nicely. So what about C? What if we cut off at C? All right, so let's go back. What are we cutting off? So we are cutting off impulses that are coming from the right eye and also from the left eye. So both eyes are affected. But which part of the retina are we cutting off? So if we're cutting off only at C, and this is not a combination, guys, it's cutting off one by one. If we're cutting off only at C, we are cutting off ipsilaterally impulses coming in from the left eye, okay? And on the left eye, we're talking about the left hemiretiny of the left eye. Okay. And then what about the one that is crossing, the contralateral one? Contralateral one is also coming from the left hemiretiny, yeah, of the right eye. So left hemiretiny and left hemiretiny. So where are they receiving their rays from? The left eye is receiving from the nasal field. Okay, it's receiving from the right visual the right side of the visual field of the left eye. Okay, and what about this one? It's also receiving from the right side of the visual field of the right eye. So right, that looks to me like it's homonymous. All right, but homonymous where? Is it homonymous right or left? For me, I'm thinking homonymous right. So this can be right homonymous hemianopia. All right, let's see if we are right. So our answer is right homonymous hemianopia. Okay, so left optic tract, see in the diagram, contains ipsilateral and contralateral fibers. All right, these are coming from the temporal hemiretiny of the left eye. Okay, this is affecting the nasal field of the left eye. Okay, that's fine. What about the other side? The nasal hemiretiny of the right eye affecting the temporal, okay, uh, temporal field of the right eye. Okay, that's fine. So since we are having right side and right side affected, we are calling this the right homonymous hemianopia. All right, so what if C was on the other side? Can you discuss how left homonymous hemianopia could come about? All right, let's see for correct on C. So C, both of them are on the right, the homonymous. Perfect. All right, so let's go to D. Now, D is a little bit different, and I'd like to go through it first, and then we'll go to the text. So, if we had a lesion at D and D only, what are we getting rid of? So, something very similar to C because it's on the same side. So, we will be having a right-sided. That's the right. What did we say? Yes, the right homonymous hemianopia, that's what we'd be having. But what would differ? So let's read this. The left optical radiation in the fissure has been affected. All right, so we'd have the left eye temporal hemiretiny affecting the nasal visual field of the left hemiretiny, and the right eye nasal hemiretiny affecting the temporal visual field of the right eye. I'm just repeating this. The only difference here is something called the macular portion. Okay, now the macular portion has a double blood supply. Okay, so even though we have a lesion that is happening at D, you find that the macula may not completely be affected, okay, because it has this blood supply uh, that is coming in not from where the lesion is and affecting all these other fibers. So because of that, you see that the middle component, the macula, will be left alone. The macula will be spared, and it will be spared because of this double blood supply that it receives from another component aside the ones that are feeding in together with the fibers coming in through D. So this is known as macular sparing. Okay, so this is explaining more on macular sparing. I need to wrap up my class. uh, to say optic fibers from the, again, we're just explaining what we've explained before. Um, Maybe before we explain this, let's look at the diagram, right? So we have the upper quadrant of the macula. Remember that this was a macular end. Upper quadrant, stay same as the retina, and also the lower quadrant is there. Then peripheral, a little bit more internal, as shown on the diagram. So the optic fibers from the upper retina um, see things in the lower half of the visual field, and they terminate in the medial half of the LBG, and they terminate on the superior side. Okay, uh, so this is just as explained. I want to go down to the macular sparing to say fibers from the macular portion separate from that, those that subserve the peripheral vision, and they end more posteriorly on the lips of the calcarine fissure. Okay, this has already been said. A macular sparing may result due to such arrangement and the fact that they receive uh, blood supply from other components of the brain rather than those that supply the uh, fibers that were coming in to subserve this area.